Well, good afternoon, everyone, and thank you for joining us today. We're excited to bring to you what is sure to be an enlightening discussion on financial toxicity and the impact on patients and solutions that we have available for patients. I'm really excited to be moderating this panel. I'm Mike Heimel, the President and CEO at the HealthWell Foundation. And many of you I know have attended HealthWell webinars in the past. This is the first one where we've offered continuing education credits for attendance at a webinar, and we're really excited to be able to kick off this series and be able to provide some continuing education to our provider, pharmacy, case manager, care navigator community. Today, I'm joined by several expert panelists who will share their experiences and insights on the issue of financial toxicity and will detail some of the resources that they offer to patients, caregivers, and healthcare professionals. They are Dr. Arif Kamal, Chief Patient Officer at the American Cancer Society, Joanna Fawzi Doran, Esquire, the CEO of Triage Cancer, and Janelle Bush, a recipient of a HealthWell Foundation Ovarian Cancer Medicare Access Fund grant, who will provide the important patient voice that we all need to hear on this topic. I'd like to take a moment and let each of the panelists introduce themselves and briefly share their backgrounds. Dr. Kamal, let's begin with you.
Yeah, well, hi everybody. I'm Arif Kamal, shared a practicing medical oncologist, and at the American Cancer Society, this is a lot of the work that we do is we think through health-related social needs and those barriers. And as a palliative care physician as well, and still practicing, these are the issues that I hear every single day when I talk to patients. And it's a way to be able to both appreciate the intricacies and complexity of someone's biology, but also to spend a lot of attention on what are really the basics of being a human and being a thriving human, a person, a spiritual being, a loved one, a neighbor, etc. And so when we think through all those personas, what we hope that in particular cancer is just one and maybe a small part of a whole person's self. And we want to make sure their experience is one that really allows them to survive and thrive. And that means that the long-term effects of financial toxicity, we hope as an organization, we can help sort of diffuse or reduce.
Thank you, Dr. Kamal. Joanna, please tell us about your background.
Hi, everyone. I'm Joanna Duran. I'm the CEO of Triage Cancer, which is a national nonprofit organization that provides free education on all of the legal and practical issues that come up around navigating healthcare and a cancer diagnosis. I've spent about 30-ish years working in the cancer community, trying to help people navigate many of the very complex systems that are involved. And while those legal issues are huge barriers, often they're key contributors to financial toxicity. And while financial toxicity is more recognized, it's a relatively new term in the research community, it's actually not a new problem for patients to manage navigating healthcare and the costs that come with a serious diagnosis. And so I'm really happy to be here today and to be shining some light not only on the challenge of financial toxicity, but some of those practical solutions.
Thanks, Joanne. And Janelle.
My name is Janelle Bush. I live in the Twin Cities, and I'm one of the really grateful recipients of a grant from HealthWell as I've gone through my own cancer journey. I've gone through cancer twice, two unrelated circumstances. So I've been involved with the whole idea of financial toxicity at the ground level. I'm a retired lawyer. I worked in government for nearly 40 years, and that's been my background that I've really kind of relied upon in terms of thinking about how to deal with these issues in my own life.
Well, thanks to all of you. If we could bring up the next slide, we have a couple of housekeeping rules for the webinar. Before we begin, the session is recorded so that if you can't stay for the full session and you want to be able to revisit the content later, you'll be able to. The recording will be shared after the session so you can relax and focus on the discussion. Everyone has been muted to maintain clear audio quality and avoid background noises. And lastly, I encourage you to participate and use the question and answer function if you want to ask a question during the presentation. We'll address those questions at the end. Next slide. And to confirm, neither HealthWell nor any of our panelists today have financial conflicts of interest that need to be disclosed. So our goal is that by the end of the session, you will feel comfortable defining financial toxicity, understand the importance of regular screening for financial hardship, be able to identify financial challenges patients face, and know the programs, tools, and services available to navigate financial challenges. But before we begin, we want to take a poll and get an understanding of everyone's experience with the concept of financial toxicity. So please take a moment to answer a few quick questions in our poll so we can gauge the audience level of understanding. So just to give you an idea of the results, interesting as we look at it, 92% of you say you've encountered a patient who had financial concerns that would cause them to forgo treatment. And 80% think treatment costs caused the most financial stress, followed by 2/3 thinking insurance issues do. So Joanna will talk a little later about how to navigate some of those insurance concerns as we go forward. Okay, let's so since HealthWell Foundation's founding over 2 decades ago, financial toxicity has become an increasingly urgent challenge for patients and families, particularly in the patients with cancer. Despite significant medical advances, rising treatment costs, coverage gaps, and ongoing non-medical expenses continue to create significant stress, instability, and real barriers to care. According to our poll just now, 92% of you have encountered a patient delaying or foregoing treatment due to financial concerns. For many patients, the cost of care has become a significant barrier. Financial strain related to healthcare has been increasing for decades and now affects millions of Americans. 11% of US adults, about 29 million people, cannot afford access to quality health care. Oncology patients are most affected. In fact, the term financial toxicity was coined in 2009 to describe the financial burden of cancer treatment. Just like physical side effects, financial side effects accumulate over time. Even with charitable assistance, many patients remain in financial distress. These numbers tell us that screening for financial risk and connecting patients to support early and often isn't optional, it's essential. Checking in early, immediately upon diagnosis, and thoroughly throughout the continuum of care helps catch issues as they evolve and the patient's needs change. Because needs change over time, what someone faces at diagnosis can be totally different months later. Benefits of patient navigation are realized in both the inpatient and outpatient setting, from fewer hospitalizations to better adherence with appointments, screening, and treatment. So at this point, I'd like to recognize Janelle Bush and ask her to share a few words about the financial toxicity and stress that she faced after being diagnosed with ovarian cancer. Janelle, could you talk a bit about your experience and what you might have done if assistance had not been available to you?
I'd be glad to do that. My whole cancer journey began about 2008. I've had 2 occurrences of cancer unrelated to each other, but I didn't know that in 2008. That was my first time, and that was stage 1 breast cancer. I was working, had good insurance, I had sick leave, and so I did not have major financial problems with my treatment and care. And so I thought I had put it behind me. 12 years later, I get the stage 4 ovarian cancer diagnosis. And that was a whole different game. First of all, I was much sicker. And I realized then that I was going to have some issues as we went along in terms of care. I think the problem is that you don't always have all of the capacity to deal with these things. And actually, you don't know what you don't know. And I might experience cancer before, about what I would be facing in terms of costs. And so I went along. I had my chemotherapy, had surgery, chemotherapy, made a difference. The reason it made a difference is because it was going to give me a better shot at survival. And when you're stage 4, you'll do just about anything to survive, needless to say. So I said, yeah, I'll take this drug, and didn't care about the price or anything. Well, its street price is like $25,000 a month. And even in those days, which was around 2022, my share of it was going to be somewhere around 8 to 10,000 in a year. And I would have to take this drug for 3 years. So, you can deal with 1 year, you can figure it out. But I was beginning to get worried. I thought, there's no way I can pay for this on a long-term basis. And who knew what I'd have to do after that particular drug. I'd already been faced with genetic testing costs. And so I knew that I was on the deep end in terms of all of the costs that were going to be occurring for me. So I said, yep, let's do the PARP inhibitor. I'll start taking it. And frankly, I was looking at my credit cards, and I was looking at refinancing my condo. And pretty seriously, that's what I thought I would have to do to manage the next few years of costs. And I'm a middle-class person. I have a pension, and I survived just fine, but I did not have the resources to cover all of this for an extended period of time. And I think about all the people I know who have fewer resources, who do not have a stable income, or who don't have even stable housing, the homeless, who I worked with in my later parts of my career. How could they even deal with these kinds of issues? And you don't know what you don't know. And those people wouldn't know either what they were facing. So you just go in it step by step. You try and be strong, and you go forward. I was super lucky that in the middle of my PARP drug experience, my friends kicked in. They helped me pay for the drug for a period of time. I was overwhelmed by their kindness and generosity. I still am overwhelmed by it. But I also was humbled. It was not something I expected to be a recipient of. I expected to be a giver. But again, when you're looking at survival, you learn to take things as they go and to be eternally grateful for your friends and for the support you get. And, this whole thing started with this slide that says, it was a thank you note, actually, to HealthWell. I just sent it off by email. And it seemed to me one of those things where, your mom says to thank people. And so I did. But I also meant it. I felt very strongly that it had taken a huge burden off my shoulders. HealthWell came in the 3rd year, and they'll pay for the drug in that year. And so I didn't have to worry about it. And that is such a gift. And that's the thing that people don't quite realize, is the energy that is either given or supported in terms of your cancer journey when someone helps you take a burden off your shoulders. You are much stronger. You can face new things and go forward. And that's why I thanked HealthWell and said I would come and talk with people today, because in my experience as a middle-class person, a lawyer who should know what they're doing sometimes, I'm a good example of how you can be surprised by the really, really high cost of some of these miracle drugs that you want and need. So again, thanks for giving me this opportunity, HealthWell.
Thanks for being with us, Janelle, and thanks for being such a great spokesperson for the assistance that HealthWell and other charities like us are able to provide for patients. Next slide, please. So now I want to open it up to discussion with our other panelists and discuss how collaboration across care teams and community partners can better support patients across the continuum of care. Let's start by discussing when. When is the best time? Is there a best time to check in with patients about financial strain, to screen them for financial stress and financial issues? Dr. Kamal, would you like to start off? And Joanna, anything that you would like to add as part of the conversation?
Well, let me echo my appreciation to be able to join you. And I always love being on a panel with Joanna because I always learn something. So I'm looking forward to hear her comments too. Let me share this. I mean, for many folks whose background may not be oncology, financial toxicity is not unique to oncology, but it is absolutely right that my good friends and colleagues Amy Abernathy and Yusuf Safar did in fact term financial toxicity. I remember them showing me a draft of that paper that was in The Oncologist back in late 2008, and I thought it was brilliant because we were putting words to something that we continued to hear in clinical practice. And for oncology, just to put it into perspective, every major movement forward in my field, in our field, has been complemented by a new way of thinking as it relates to supportive care. So, for example, in the 1970s, when we were really a brand new field, we were doing, for people who might know, the term radical mastectomy. And what made it radical was not that it was radically cool, but that it was radically morbid for people. And we thought more was better. And that's how we practiced. And what we failed to recognize is that it just wasn't feasible, frankly acceptable, and in some ways humane, and ultimately the best impact to do all of that, including taking the breast tissue down to the pectoralis muscle. And so, as that evolved, we became more astute to the supportive care needs of patients, and thus we could evolve into a new generation from primarily surgical-based management to really now involving chemotherapy and other systemic treatments. At that time, then, for those who might remember what chemo looked like in the 1990s and early 2000s, it was exactly what you would picture. Women with no hair, men who are bedbound, people are sick, nauseated, throwing up, etc. And so what you picture is something that is still hopefully a historical and not current picture of what our field looks like, which is one where we paid so much attention to killing cells, we stopped worrying about helping people. And as we, created antiemetics and other very modern approaches to supportive care, including the growth and proliferation of the field of palliative care, we started to understand that financial components was a part of the overall suffering, sort of distress that people were going through in particular. And I think that brings us to current day in oncology. Again, while we're not completely unique, what have we solved for a little bit? Well, 30% of our drugs are oral, right? And so in many ways, many of our medications are easier to tolerate physically. So from the aspect of physical toxicity, we're certainly making a lot of headway. What we did not yet solve for, though, is this growing financial toxicity. So as you can see, as oncology has progressed, it has had to, as a stepping stone for progression, to solve for these supportive care needs that we are placing as challenges in front of people, whether that's physical morbidity, logistical challenges, or in this case, financial toxicity. So to Mike, to your good question of when should we start to do this? Well, I think I previewed a little bit of this challenge is that when people enter a cancer journey, very few people plan for it, right? When I talk to my patients, they talk about their hopes and dreams and everything that was sitting in front of their life, and then oops, this thing happened. And that their financial planning was not centered around this idea that they could be potential at financial devastation through something. People had thought, well, I've got insurance, so it should be okay. And that was maybe a false sense of protection. And also the out-of-pocket costs that can affect people in cancer and many other things too, related to any number of requirements we have outside of the infusion itself that requires wound care and other things too, as you can imagine, is oftentimes underappreciated as well. And our ability to even predict what those impacts are going to be to people, I, as an oncologist, my confidence interval is very wide when I talk to patients. And sometimes the answer is even an unsatisfying, I'm not sure. And so, to the question of timing, and I would invite Joanna to talk too, is it's early, it's often, and I would say importantly, it is with a tone of compassion and curiosity and collaborative problem solving. And I remind to all of us, it cannot be through a tone of judgment or critique. And oftentimes, I think when I talk to my colleagues, they say, well, how do I talk to a patient about this really important topic without sounding judgmental or I'm critiquing them? And I said, therein lies the answer. Just do it without sounding judgmental and critiquing them. So, with a spirit of curiosity, ask, because ideally we can solve for something together. And remember, there's typically not a false choice between the best care and the care that most aligns with someone's financial realities. And importantly, I think we believe in transparency. And ultimately, as a palliative care physician, if I know that someone is making decisions based on financial legacy or their ability to do other things or to make the right opportunity costs in their life, is it not but only fair to tell them what the different inputs and outputs are for them to make the best decision for themselves? So with Joanna, I'll hand it over to you.
Thank you. So I think I would say, along the lines of how oncology care has changed over time, also the focus on financial toxicity has changed really significantly in the last 20 years. And I think we started with asking research questions about, are patients experiencing financial toxicity? And for those of us who have been doing this work for a long time, we thought, well, yes, of course patients are. But we had the research then to prove it. And so then the question became, well, if patients are experiencing financial toxicity, how do we screen for that? And I think we're a little bit stuck there right now in the research community of like, how do we screen appropriately? Where some of us have actually already moved on to how do we actually solve for it? What is the intervention that we can use to actually not just address financial toxicity, but how do we help people avoid it? And so I think that's where we need to move some of these screening conversations. And so to Mike's question about timing, that's a key contributor to how we can help people avoid some of the financial toxicity. So if you think about oncology as an example and the variety of different types of care that someone might be experiencing based on their diagnosis, the question is, well, when do we screen? And really, screening is stuck right now at diagnosis. If you ask somebody at diagnosis, are you experiencing financial hardship? There will be a group of people who will say yes, because their existing financial situation was already difficult. And now we've layered in a cancer diagnosis on top of it. That's an important time to catch people because, again, we can help people try to address some of that financial need and some of those contributing factors to financial toxicity. But for many people, the answer to that is going to be no, I haven't started treatment. I haven't gotten my first bill. I don't actually know what this is going to cost me. And so I'm not yet experiencing any hardship yet because I haven't actually had to pay for something. And so then it's important to think about, well, how can we ask these questions again when treatment actually starts? And have conversations about what that treatment actually is and then what it's going to cost someone. But that layers in another challenge. So Dr. Kamal mentioned most providers are going to tell me when I tell them the importance of having cost conversations, I don't know what it costs somebody. I don't know what somebody's treatment is going to include. So how could I possibly tell somebody? Because I don't know what all the things that could happen, even if somebody has complications from treatment. You don't know that ahead of time. But what you do know is what type of insurance somebody has. And you do know what their out-of-pocket maximum is for their particular plan. And that can be communicated to a patient so that in a worst case scenario, based on whatever type of treatment you have, the most that you're going to pay out of pocket this plan year is this dollar figure. So when we're doing insurance assessments, that's key piece of information can be communicated to patients to try to help people understand what cost is actually going to look like. So then we have some other gold standard times where somebody might want to take this into consideration. So 90 days after someone's treatment has begun, if they're taking time off work, 90 days is when the FMLA expires. So that could contribute to workplace changes, which contributes to income changes, which contributes to financial hardship. So at that point, checking in with a patient to see what needs they're experiencing and what potential financial hardships they have and what next steps look like. Like, could we tell somebody about their options for disability insurance at that point? And then if somebody's treatment changes, that's a coverage issue. So changing treatment, we want to make sure that insurance is actually covering that new treatment. And what does that mean for changes in out-of-pocket costs? Same thing if treatment moves to another stage. So if someone has surgery and then moves to chemo or to radiation, that change in treatment, again, is going to impact what costs are coming from somebody's insurance coverage. If somebody moves to a clinical trial, same thing. How is insurance going to cover that trial? And what does that mean for out-of-pocket costs for a patient? And then the other piece is either at the beginning of a calendar year or at the end of a calendar year might be a time to check in with somebody, but we also can't assume that somebody's insurance is going to change at the beginning of a calendar year. Because if someone has an employer plan, for example, that employer plan might change in the middle of the year. So they might have a May 1 new plan year. And that new plan year is going to come with a new deductible and a new out-of-pocket maximum, which means those times are going to trigger financial hardship for somebody. So this is just one example of how there could be a variety of times where healthcare teams can be checking in with patients about how their financial situation might be impacted by their care over time.
Thanks. Great insights from both of you. One of the things I want to ask, though, Janelle, when in your treatment did someone first screen you for financial challenges or begin discussing financial impact of your care with you?
You know, they didn't until I worked with a specialty pharmacy in the last year of my treatment with the PARP inhibitor. So at the very end, the last year, when I found out about HealthWell, it was because of the specialty pharmacy, you know, trying to deal with the cost. They knew I was experiencing really high costs. They knew that I had been doing it for, going on 3 years. And so that was it. You know, I'd like to make a comment about what's been said about how often you need to talk to people about this. It strikes me that you need to know the emotional landscape that people are in. I was writing my will, at one point when I was with the stage 4 diagnosis. And so when people talked about costs, I really didn't care. I knew that if I had to do it, I would put it on a credit card and I didn't give a damn. And I think that kind of attitude of desperation is not quite able to be discussed in a way that makes some sense for people. And I think also the fact that you really don't even know till the last minute how much the costs are really going to be is something that's underemphasized. I went through a point where my drug was rejected by my insurance company. It was a 2-year drug. But the one I went on was a 3-year drug. So what? Well, it's another $10,000, $20,000. I mean, those are the kinds of things that can happen at the last minute. I just wanted to talk about how chaotic it feels for the patient when they're going through this and what their emotional layer is even at that point.
Great. Thank you so much. Let's go to the next slide. And Joanna, I think, one of the things we want to talk about is the contributing. Oh, I'm sorry. First, let me back up. So our poll earlier shows that about 80% of financial toxicity appears to come from treatment costs as the most stress for patients. It's not the only cause, however. And Joanna, would you agree and discuss that further?
Absolutely. I also just want to thank Janelle for reminding us that this is layered in. This need to talk about cost and how we can support patients is layered in on a whole lot of other things that are important to patients. And I think that where we are having cost conversations, it's also really important to normalize them, and that financial challenges are incredibly common, and that there are some things that we can do to support people. And so I think it's more than just saying this is what it's going to cost you, but how can we better support patients through that? So it's not just about screening, but then what are we going to do about understanding what patients' financial needs are? So I just wanted to say thank you for reminding us of the importance of that landscape. I think we spend a lot of time talking about the cost of care in the cancer community, and that is certainly understandable when we talk about the extreme costs of the new treatments, especially that are coming out. But it is actually only one contributing factor to financial hardship. And having insurance coverage, we believe, is actually one of the biggest contributing factors to financial hardship. It's not just having insurance, though, it's having adequate health insurance coverage so that you're minimizing your out-of-pocket costs and that it's coverage that's actually covering the care that you need. So insurance that doesn't cover your providers and doesn't cover the drugs that you need to access, that's useless to you. And so making sure that people understand how to pick the best health insurance coverage for them, and frankly, their budgets, because we're in an environment now that what somebody would have chosen last year is not something they can afford this year. And so keeping that in mind, How can we help people make those educated decisions? And then once you have insurance, that's really only step one. You have to know how to use it. So you have to understand networks and you have to understand how to choose a plan that covers your providers. You have to know what to do when your insurance company says, no, we're not going to cover that. And what your options are for appealing those types of decisions, but also understanding the federal, the state, the local laws that actually provide protections to you as a healthcare consumer. That's a lot of work. We don't go to high school and learn all these things in high school. And so, unfortunately, we're trying to learn all of this information when we're diagnosed with a chronic or serious medical condition. And that's an added layer of stress. But there's also things like loss of income is clearly going to impact someone's financial situation. If you can't work and you can't pay your bills because you're no longer working, clearly going to have an impact. So how can we support patients in understanding their options for accommodation so they can stay at work if that's possible for them, or how to take time off and protect their job, or how to access disability insurance to replace lost wages? And as I mentioned, someone's existing financial situation is going to contribute to all of this as well. Not everybody has access to retirement accounts that they can tap into or savings. We know that across the United States, very few people actually have $500 in emergency savings. So if you are diagnosed with a serious medical condition like cancer, it's probably going to cost you more than $500. And then clearly all the things that happen in life other than a cancer diagnosis can impact your financial situation. So if you have to move or you graduate from school or you get married or divorced, those things are going to impact finances too. And so when we think holistically about how to address financial toxicity, we can't just be talking about the cost of care. We have to be able to provide information and support across all of these areas as well.
Yeah, thanks for bringing that up. You and I discussed previously the concerns that I have about high deductible health plans and the increasing size of deductibles. And, it lowers your overall premium month to month. But if you don't have $7,000 or $10,000 in the bank just for the unexpected healthcare event, you're going to face a significant financial challenge in the future. So very, very important comments. So now let's turn our attention, or first let me ask, Arif, do you have similar experiences that align with Joanna's?
Yeah, unfortunately, every 15 seconds someone hears the words you have cancer. And so that's every 15 seconds someone's life changes, and that includes their financial life. Of course, Joanna's correct. I'll add just a little bit more context. So, I think in the standard of care space, right, we would love to believe that the pricing of drugs is rational, and that's not a judgment, though I might share my judgment and privately. But you'd love to believe that if drug B is 25% better than drug A, the drug B would be 25% more expensive than drug A. That would be one way to think of a rational line that might graph two things at the same time. The reality is rarely does that actually borne out that way. That in fact, drug B might be twice as much or three times as much as drug A, though it is 25%, better. There have been solutions sort of posed about how to address that, and that's not for today's discussion. But I do want to point that out there that I think patients many times who still bear the out-of-pocket cost of maybe a copay, for example, related to a drug, may think that way too, right? So when we as oncologists present options and say drug B or drug A, a new study just came out, drug B is 10% better than drug A. What do you think? And I think it's important to also say, that there are physical differences, side effect differences, cost differences, et cetera, and it all really gets to an informed decision conversation. In addition, I'll share, the FDA has approved more drugs in the cancer space in the last 10 years than any other space, period. And it's improved more drugs, period, than any other time in history. That means that this complexity of what Joanna's talking about is insurance coverage and what it's going to be and look like and so on is a lot of cognitive burden for any one person, right? And so I think we have to work in teams to be able to do that. As a lowly oncologist, there's a lot of other things I have to, address. Certainly, as was described, I need to bring it up. But I do want to work with a team with, financial counselors and navigators and others to be able to kind of work through this together, because insurance coverage changes, policy changes, drugs change, and new things come out, including indications change as well. And so something that's on label might suddenly become off label because of something that happened yesterday in a formulary change that I may not be up to speed on. And then lastly, I'll say about clinical trials. the price of progress in oncology is personalization, and that's a good thing. But let's just imagine for a second that there are 50 different types of lung cancer, and you've got lung cancer type 47. Well, the drug for lung cancer type 47 might be in a clinical trial, and it's very likely that you might live in LA, and the clinical trial for that drug is actually in a cancer center in New York, right? Because if there's 50 different types of lung cancer and there's 50, let's say 50 trials, you wouldn't open all of them across the country, right? You would actually get to smaller sample sizes for the trials and more limited places for where those trials are going to occur. So you imagine the patient who's seeking that trial, that's not going to be a generic trial, be a very specific trial, lung cancer number 47 trial, may have to now travel. So imagine time away from work, the cost of travel, lodging, transportation, other things that we, for example, address and HealthWell does too. But that is cancer care today. So when I think one of the science fiction writers said the future is here, it's just not evenly distributed. That applies here 100%. That clinical trials are the future, innovation is the future of cancer care. It's just not evenly distributed, right? And that's not an equity problem per se, but it is the reality of where we find these things. And for many patients, we find that increasingly they have to travel, and the costs associated with that are oftentimes underappreciated as well.
Thanks. I just want to pause. I know we said we do questions and answers at the end, but there's one that's come in the Q&A that is on this topic, and I want to make sure we cover it before we move on. And Joanna, the person asking the question is asking to clarify, was it stated that advising the patients of their maximum out-of-pocket cost is the best first step in helping them understand treatment costs?
I think it is a very useful step, because when patients are concerned about cost, or want to know how much it's going to cost them, which is two different things. What treatment actually costs and what a patient actually pays for that treatment is totally different based on somebody's insurance and based on their out-of-pocket maximum. And also what other care they've had during the year. If somebody has already met their out-of-pocket maximum for the year, they may pay zero for the rest of their plan year related to their cancer care. So it's not a one-size-fits-all answer. It does have to be a customized answer based on a patient, but it is accessible information.
Yeah, and I think that's really important when you consider the Inflation Reduction Act caps on Medicare Part D. For example, this year, a patient's maximum out-of-pocket cost for Part D medications is $2,100. And unfortunately, in the oncology space, that's usually the first prescription, and they've met that out-of-pocket cost for the year.
Right, and everything's relative, right? We're so happy, for lack of a better word, that we now have an out-of-pocket maximum for Medicare Part D, but it's still $2,100. That's still a huge amount of money. But compared to $100,000 out of pocket, that feels so reasonable. So we still have to keep in mind that even though there's a cap now, it can still be a burden.
Great, thank you. So now let's turn our attention to how we in the patient support community can help patients. I'll open the floor first to Dr. Kamal, who will share information about the patient support programs available from the American Cancer Society. Dr. Kamal?
Yeah, thanks. I have such the privilege of working with so many dedicated volunteers and donors and team members on my team who wake up every morning thinking about how to work in community to solve some of these issues. So I was previewing a little bit of this issue related to travel, and maybe I was previewing my slide here a little bit. So, what we find is that the thing that hasn't changed, right? I just mentioned there have been 300 new drugs approved in the oncology space in the last 15 years or so. I mean, it is remarkable. I have a hard time keeping up. Okay. What has not changed, right? In the 1960s, we were using nitrogen mustard gas to manage cancer. Okay. That's within many of our lifetime. What has not changed during that period of time is the need for lodging and transportation. Because what ends up happening, right, is that costs shift, right? It costs money to be human, it costs money to have families, it costs money to survive and thrive. And the reality is when you pull it towards medical expenses, it might pull away from the other things that you would typically use your money for. And again, as I was mentioning in the example of clinical trials, you may need money to stay in a place and get to that place. So we have two programs here, as you see. One is called Hope Lodge. I would say this is maybe one of the most under-recognized programs we have, and it bothers me, so I'm here to tell you guys all about it. So we have 31 of them across the country. The idea is no cost. Let me say that again, no cost. That means no cost housing for people who are accessing treatment in these communities that are here. Now, if we're up to me, we would have a zero behind the 31, but alas, they are somewhat capitally intensive to build and to maintain. But what we do is we find that people, particularly who are finding that financial toxicity is cumulative. I started by saying that for many people, this is a marathon, not a sprint, right? This is not running an errand, right? Not to oversimplify it, but when you run an errand, it's time bound, it's simple, and you know when it ends. And for many people with cancer, including those we call cancer survivors, the component of an end is somewhat diffuse, right? End is sort of in the eye of the beholder, but for many of our patients, they remain on therapy for years, and in my clinical practice as a breast oncologist, for decades. And so at that point in time, some of our patients may not have, as Joanna was mentioning, sort of financial toxicity that's apparent or let's just say painful yet in the first couple months, maybe even a year. But that financial resilience is fundamentally a function of time. All of us are financially resilient to a certain extent. But the reality is that if cancer affects you for 20 years, very few of us on this call would still be in a similar financial situation 2 decades from now compared to today. And so for many of our Hope Lodge guests, some of them come newly diagnosed, and for others, they really are on a journey that is longitudinal and measured in years, and the financial toxicity has caught up to them, and the pain is too much. And so for them, on average, they stay with us for 17 days. For some, they stay for up to a year. And for many of them, they are accessing those cool, innovative treatments that are complex, expensive, and require time. CAR T, ADCs, bispecifics, those things we all hear about, they are complex and they require a place for caregivers to stay, et cetera. And so for us, last year we served nearly 550,000 nights. If you just put a dollar figure to that, that's 55 million if it's $100 a night for a hotel, which I don't know anywhere we can say for a hotel for $100, but you get a sense of the magnitude of savings that we can get to. And you can see where we're moving. For those of you who are paying attention to the map, we're very much East Coast and Midwest centered, and I promise you we are trying to change that. On the road to recovery front, again, Hope Lodge communities have been around for 55 years. And so as I tell people, 55 years, a lot of things have happened in oncology, including we stopped giving nitrogen mustard gas for the most part, but we have not yet solved for this issue. And so Hope Lodges are just as relevant today as they were 55 years ago. Road to Recovery has been around for 43 years. This is a similar program to bring transportation solutions to people for whom have to go at least 20 miles or typically an hour. And that might be in your own backyard. I challenge anyone who lives in Queens to get to the upper part of the Bronx any quicker than 30 minutes or so, and certainly not with as much snow as I hear they got. And so this transportation can be local-ish. It can be farther than that too. We've had volunteers put together daisy chains of rides to go from North Carolina down to Georgia through South Carolina, where really it is a team effort to do that. And here we find that for many patients, this is the number one barrier for a missed appointment. And really, we believe by empowering volunteers, many of them survivors, many of them caregivers, and some of them the bereaved, to give back as part of their legacies to participate in a program like this. We are on track to give 90,000 rides here very soon with over 7,000 volunteers. And again, it becomes one of those collective solutions to offload just one more thing that people have to think about or worry about through the American Cancer Society's program. Oh, I'm not done, Mike. I've got more for you. So, obviously, lodging and transportation are number one and number two. But the other part about this we have to recognize is the need for connection. I have thought for a long time, and I had thought as a baby doctor, as a junior oncologist, that cancer is a connecting moment. It's a galvanizing moment. It's a moment where communities come together. And while that is the story for some, I will tell you in the patients I've taken care of for years and even decades, that they almost to a person become more lonely and isolated during that period of time. Because the reality is that most of our relationships in life are either tied to our profession, our kids, something that involves an activity. And I would say at the same time, people don't like talking about cancer. So the people that were your friends, your acquaintances, your neighbors have that sort of awkward pregnant pause. So, Joanna, how are you doing? And once they get through that awkwardness, maybe they might stop talking to you altogether because they just don't know how to engage. And to Joanna's point, we didn't spend any time in high school actually knowing or being trained how to talk to each other when we're going through a difficult thing. And human nature sometimes is to pull back, despite our best intentions. And so our data would show that 60% of people going through an active cancer diagnosis are more socially isolated than before their diagnosis. So how do we think about connection? Here's two ways on the screen here. We launched our first ever patient support app called ACS Cares. And while it does a lot of things, I'm going to point out one of the really, really cool things it does is it connects someone going through an active cancer diagnosis with another person who has that similar lived experience. We actually use a dating app methodology to do a connection, which I say somewhat cringy because I've been married for 18 years, never used a dating app, but my colleagues who have tell me they work really, really well. And the idea was find someone like me so we can talk about the things we both care about. And that's what CARES does. In addition, we have been for over 40 years had a contact center at the American Cancer Society. It's the most contacted contact center in the world, 24/7, 365. We use phone, live chat, and video chat, as you can see here, so that any person at any point of the day or night, we can be that voice on the other end that is compassion, support, and resources. Every year we get about 350,000 calls, a mixture of that of people looking for resources, but nearly half of those calls are related to wanting a compassionate voice on the other end. The reality is that many of these pressures we're talking about, such as financial toxicity, can bring about feelings of shame, isolation, or even a hesitance to share that with others. You can imagine a spouse, one has cancer, the other one does not. The other one is taking on extra shifts to manage their out-of-pocket expenses. And the worry about that, the person who's taking double shifts is stressed, overwhelmed, but does not want to tell her loved one who's going through the cancer journey. The person going through the cancer journey wants to express gratitude and appreciation, but maybe doesn't know how and doesn't want to bring it up. So you imagine there's this sort of conspiracy of silence a little bit. They both appreciate each other so much, but maybe they don't have the language to talk. And so we end up sometimes being the voice that you can talk to give you some guidance on how having that conversation should occur. So we're very proud that these are two major ways we've done to try to close that loneliness, social isolation gap that we know is very prevalent out there.
And I believe you've got one more.
I do. It was so compelling, so I'll try to keep it up. So these last two is really around connection to care. So while we as an organization do not provide clinical care, we want to connect people to that, right? Making care possible for people who might seem that care is out of reach. The first one is our Leadership in Oncology Navigation program. As many may know, and I think some on here who are listening are navigators. You might remember, right, that the federal policy regarding reimbursement for non-clinical, I don't like the word lay because I don't think there's anything lay about this, non-clinical navigators, that there's a reimbursement pathway through Medicare fee-for-service schedule, and that's called PIN codes, or Principal Illness Navigation codes. What we stood up here, actually, with a very memorable call from the White House to the American Cancer Society. It was a fun call, actually, from the First Lady to really stand up a program like this, to have a credentialing a pathway, education credentialing pathway, to really build the nation's capacity for non-clinical navigation in oncology, and to make it sustainable and scalable through reimbursement, through fee-for-service, and importantly, that the credentialing and education component of that is something we took on. And I'm very proud to say we've credentialed nearly 1,500 oncology navigators now so far, and are expanding that program to include emphasis on financial toxicity navigation, supportive care navigation, even specific diagnoses like breast cancer as well. Our ACTS program is, I'll give you a fact that most will not probably know. If you had to guess what % of adults who are eligible for cancer clinical trials actually enroll in that clinical trial, you're probably going to guess a number that's higher than the actual number. The actual number is 7%. That's extraordinarily low. When we think about all the things I mentioned, innovation, cool new therapies, that less than 10% of those folks are accessing it. And we saw at the American Cancer Study that one of our highest and best uses as an organization would be to, through our 1-800 number, connect people using AI, because of course you have to today, or otherwise it's not cool to talk about, connect people to the right clinical trial for them. But importantly, to recognize that finding the trial may not be the entire problem. In fact, for many people, that's not the problem. The problem is saying, well, then, Dr. Kamal, how do I get there? How do I afford getting there? Who's going to watch my kids while I'm going there? How am I going to fly there? And all the parts of life that continue to still be a challenge, even though a clinical trial is in place. And so what we've done here is to wrap around our services from the previous slides I showed into the clinical trial matching. So not only are we asking which trial is best for you, let's find one, But then we're asking the second and potentially more important question is, how do we get you there? And fundamentally, we believe we can be a small part in solving that for the country by putting those pieces together. Okay, Mike. We do other things too at ACS, but I appreciate everyone indulging me talking about some of our programs.
Yeah, I'm just, American Cancer Society has so many resources available, and some of the publications, Cancer 2026, Cancer 2025's got great statistics about what is happening with cancer care and cancer diagnosis across the country. So ACS is a great partner for us, and we love working with you, Arif. So I'd give you 4 more slides if you want.
Likewise, but I want to hear Joanna talk. So let's hear about triage cancer.
You can do my slide for me.
No.
Joanna, tell the attendees about Triage Cancer Services.
So we acknowledge that the information around insurance options and navigation and employment rights and disability insurance and all of the healthcare consumer laws, those are not things that are taught in traditional healthcare team education models. And most of this information is actually learned on the job. And so Triage Cancer actually exists as an education program specifically to support patients and caregivers and healthcare teams. Because we know if we can put this information in the hands of healthcare teams, we can exponentially reach more patients and caregivers with this information. And so we do have a lot of programs and services specifically to support healthcare teams, including our insurance and finance intensive, which is a full day accredited training for nurses, social workers, patient advocates, and really any other members of the healthcare team who might be getting questions about health insurance, employment issues, disability benefits, and finances. And we really try to address the underlying causes for financial hardship and how to mitigate them. All of our educational events, though, our conferences and monthly webinars are also accredited and have free continuing education as well. And then we have hundreds of educational materials and resources on a variety of different topics. Our print materials can actually be ordered by healthcare teams to distribute to patients and caregivers. That is free. We will ship them for free. But we do also have some other things like animated video series and our podcast that is trying to address some of these topics because we know they're not exactly the most exciting things to learn about, but they are incredibly important for people to navigate. And so we try to present the information in lots of different ways to help people learn. We do know that all of those things might still lead to people having individual questions about their situation. And so our legal and financial navigation program is a free resource where people can set up time to talk with our attorneys for free. And to learn about health insurance options and how to make changes in insurance coverage and how to deal with work and how to make sure you have estate planning and medical decision-making documents in place and all the other questions that might come up for somebody. And patients and caregivers can come to us directly through this program, but we often find ourselves serving as technical assistants for healthcare teams as well, where healthcare teams are frequently getting asked repeated questions by patients, and they want to learn so that they can be able to answer those questions for all their patients moving forward. So we do provide that service as well for healthcare teams. I also just want to mention that we also are engaging in a lot of research with cancer centers across the country around financial toxicity interventions. So how can we start to test how to support patients once we've screened them so that we can create some best practices for healthcare teams to be able to use moving forward. So again, all of these programs and services are free. And we often actually hear from healthcare teams that they would like additional materials created. So we often hear from healthcare teams, I would really like a one sheet on X topic. I can hand that out to my patients because I keep getting asked this question. So we feel like it's a very important partnership with healthcare teams to be able to support patients and caregivers through these issues.
Great, thank you. And I know we've got a few minutes left. I'm going to give you a summary of what HealthWell has available, and then we'll have a few minutes for some questions and answers. So HealthWell offers assistance to patients facing financial toxicity through our charitable patient assistance funds. Some of you may be familiar with the funds that we provide to help offset the high cost of medications. But as we've discovered today, financial toxicity encompasses more than just high-priced drugs. Therefore, I'd like to take a few minutes to just talk about some of the non-medication funds that we offer. HealthWell has funds to cover travel expenses, cancer home care services, and we even created this year a fund to help people offset the higher cost of premiums on the ACA marketplace. And we've got some other funds that don't fit neatly into disease funds, such as we've got some funds available where we may be able to help a patient who loses insurance coverage once they're under treatment, bridge that gap until they're able to obtain new insurance. Our general travel fund offers assistance to patients who have an active HealthWell grant. So if we have somebody with, say, a diagnosis of multiple myeloma who is trying to get to a clinical trial on the other side of the country, we've got funds available to be able to assist that patient getting linked up with those trials. And our Cancer Home Care Services Fund helps to cover the out-of-pocket costs for the home care services and durable medical equipment that patient may need as they're going through their treatment. Next, please. And then just briefly talking about our ACA Marketplace Premium Insurance Assistance Fund. We launched this in November of 2025 with a $120,000 grant that we received from a generous donor. And we've been able to award 80 grants so far. The grant amount is $2,000 a year for patients who have an income level of less than 200% of the federal poverty limit. Unfortunately, this fund, as many of you know, with the demand and the changes in the ACA marketplace, is very popular. And so we're constantly seeking new donations so that we can continue to help these folks keep health insurance so that they can better afford their treatment costs and their medication costs. I am going to jump to a couple of questions that have come up in the chat. What I'd like you to do, Audrey and Crystal, is bring up the continuing education credit slide, because I know a lot of folks are asking how they can get credit for their slides. And this is the one that works for that. One of the things that I did want to get to is there is a question here about the value of resource navigation in the healthcare system. And as a hospital CEO, I can tell you that care navigation, financial navigation is incredibly important especially for people with chronic and catastrophic diseases. And we often underinvest in it. I oversaw one of the largest cancer centers in the Department of Defense, and for 9 different specialty centers in cancer, we had one care navigator, a licensed clinical social worker, to help with that. And there's questions in the chat about financial navigation and if it's a course someone can take. And we've got a number of great financial navigators we'll have in a future webinar that we plan to do later this year. But I'm wondering if the group could talk a little bit about the importance of resource navigation at the practice level or the health system level. Janelle, how important would that have been to you, and did you encounter any resource navigation?
It would have been really helpful. I think I didn't really encounter it until I had access to a specialty pharmacy that had a program for people to figure out, the cost of drugs. So I didn't have one that was more general. And it would have been good because it would have raised the right questions for me to then begin to deal with, from the beginning, rather than on an emergency basis.
Great. There's also a lot of questions in the chat about, particularly for HealthWell funds, how can you tell when a fund is open? If you go to our website and you sign up for real-time fund alerts, you will get a text message whenever we open a fund or reopen a fund for new enrollments. And you'll be able to track them that way. Dr. Kamal, a lot of questions in the chat about expanding ACS's programs to the West Coast. and I imagine the Southwest as well, since there's a large population shift to states like Arizona. And
Yeah, indeed. It is on our roadmap, and I can't share a whole lot publicly yet, but I hope you see the smile on my face to indicate both agreement and a plan that is coming together. But I do share the sentiment, right? Is that, the types of challenges people face, you can't always predict or sort of lump people in a box and say it's going to be this type of person who's going to need that particular need. I'm very proud as an organization at ACS, we serve 75% of all zip codes in the country through existing services, meaning if you look at who we've served last year, calendar year, we served someone in 75% of all zip codes. So we're getting there. But I also appreciate that no one organization can do this alone. So while I'm talking about our services, the friendship and collaboration with both Triage and HealthWell is genuine and sincere. And fundamentally, while we have 350,000 people call us, very frequently we refer back out to organizations like yours and others. To the question about resource navigation, I will share, and then hopefully someone can share on my behalf to the larger chat, kind of what we use at ACS that people can publicly access. We have a relationship with an organization called Find Help, which used to be called Aunt Bertha. Others do as well, but you can do sort of a zip code based search of free and reduced cost services that are both ours and others through that. In addition, if you call our 1-800 number, 1-800-227-2345, I have to memorize that because it's my job, but you don't have to. You can Google it. But if you call us and you ask for help and say, I need food and I live in Memphis, Tennessee, that's exactly what we do with you on the phone, is try to navigate to that.
Right, and there is a question here for the lawyers in the group. So Janelle, you can join in on this one.
Retired, no license.
They they asked if you could discuss patients regarding disabilities and free resources and information that may be available, um, and how they can apply for them. They have a number of patients that come in and ask if they meet criteria and who have been denied and want to reapply. And I think specifically with Social Security Administration. Joanna?
Yeah, so disability insurance means different things. So what somebody has access to depends on potentially their employer coverage, it depends on what state they live in, and it depends on their medical condition. So there are private disability insurance options that are policies that you can buy directly from an insurance company. But the pre-existing condition protections that exist in health insurance do not exist in disability insurance. So once you have a serious medical condition, it is very difficult to buy a policy. Most people who have private insurance get it through an employer as an employee benefit. And when I ask somebody, do you have this through work? I almost always get no is the answer. And I'm like, double check, because it's usually just a piece of paper they sign on their first day of work and then they forget all about it because the employer pays the premiums and they don't remember that they have access to it. So it's always worth double checking. Then there are 5 states and Puerto Rico that actually provide state disability insurance. Those are California, New York, New Jersey, Rhode Island, and Hawaii. So in those states, as an employee, most employees pay into the state system for state disability insurance, where it's a payroll tax. And in that case, you have access to short-term disability benefits, which could be 6 months to a year, depending on which state you live in. Then there's the federal disability program, which is Social Security Disability Insurance, SSDI, or Supplemental Security Income, which is SSI. They both have this same very high standard of disability in that they don't just expect you to have a medical condition. It has to be expected to last at least a year or longer or result in death. It has to impact your ability to do your current job and any job that you've had for the last 5 years. So all the laws and programs that we talk about have a different definition of disability. So when we talk about is cancer disability under the law, the answer is it depends on what law we're talking about. And on an individual's situation, because it's how somebody's medical condition impacts them specifically. So whether or not they qualify is going to depend on them specifically, their medical condition, and their job. And so that's the fastest overview of disability insurance that I can provide. But we have a lot of information and resources, both at Triage Cancer and at Triage Health, on disability insurance options, and then sort of tips for applying and appealing. Because with SSI and SSDI, 65% of applications are denied the first time around. And I think Janelle can.
I'd like to add to that a little bit and say that when I worked at the Department of Human Services in Minnesota, there were a number of programs that would connect people with disabilities with resources. And actually, they were pretty good. And we also had some connection, of course, with Social Security. And so we had people calling us because they couldn't get through to the Social Security Administration, which is certainly going to be true as we see reduced local offices and local office staff. So I wouldn't discount the idea of calling your state programs and see what helps.
I would also just add to that point, if somebody is having challenges with the Social Security Administration, your members of Congress are a resource for you. So you can contact your member of Congress and say what you're having trouble with, and they often have staff who are called case managers or constituent services managers who actually can interact with that agency to help you. So remember that they actually can be a resource for you.
Yeah, and then the last question, because we're running out of time, but if you have a question in the chat, we will answer every question that has come into that Q&A box, and we'll try to get through that today. But this is an important one, and I want to cover it. Is there a screening tool that can be shared? This individual is a medical social worker who works with dialysis patients, and Dr. Kamal in particular, I'm wondering, I'm familiar with social determinant of health screening that's required by the Joint Commission of Hospitals and Health Services, but is there a good template that we could put out there on our websites that would be available so that social workers, nurse navigators, providers would be able to make sure, in addition to the social determinant of health screening that we should be doing periodically during our engagements with patients, we're covering the financial toxicity topics that we really should be hitting?
Well, I'd ask Joanna as well. I mean, there are a couple different tools. For us, we use a 10-item health-related social needs questionnaire, so we try to get at it from multiple ways. I would say this is a place where perfection could be a bit of the enemy of the good. In the academic world, there's lots of robust conversations about which one might be the right one. I would say that in my clinical practice, I'll let Joanna talk about tools, but in my clinical practice, it's really again in a compassionate way, just sort of saying, tell me how sort of the cost and the logistics of your care are sort of affecting you in general, right? Sort of kind of a high level question. And it's not a yes, no, because I'm saying, tell me how. We're going to presume that there is some stress someone's saying. And again, it's not a judgmental thing because you're actually normalizing it by saying, I know this is affecting you in somehow. They might say, well, it is a little bit, but it's not too bad. And then what you're doing is you're opening up a conversation to say, I'm committed to having this conversation with you over the longitudinal nature of our relationship. So I've just normalized it from the very beginning that this is going to be something we're going to talk about, right? I'm going to ask you a social history and a family history and a physical history, and I'm going to listen to your heart and lungs. Like, it's just a part of our interaction. And however one finds to do that in a culturally competent way and in a way that fits into the natural flow of the visit is sort of how I prioritize. Joanna, what would you add to that?
What I was going to say, I actually like your question better because it is a better way to bring up the conversation and it normalizes it for people. So I do really appreciate that. But to the specific question we were asked, I would say that in addition to social determinants of health, there is also the distress thermometer, which as a social worker is probably a tool you might already be using. There's also cost facet. I already shared that I feel like the tools that are being used have limitations, and they're asking about the way the questions are phrased. It's asking if somebody already has hardship, as opposed to asking the question, do you have questions or concerns about this particular topic? Because someone might have walked into the appointment without any questions or concerns, but if you phrase it that way, they might actually stop and think, well, are there questions I should have that I don't know to be asking? So it sort of brings up the conversation in a way that it's not just saying, do you already have a financial problem? So it makes it more of a conversation as opposed to that yes, no answer.
Wonderful. And Dave Becker put into the Q&A that NCCN guidelines have a tool called the distress management tool that some folks may want to take a look at as well. So thank you for that, Dave. Well, I want to wrap it up, and I want to thank everyone for their attendance, and especially to our panelists. Janelle, wonderful to see you as always, and look forward to talking with you in the future. Joanna, I think I'm going to see you in Philadelphia in a couple of weeks. And Dr. Kamal, I look forward to our continued relationship. And I want to give a special thanks to our external relations team, Audrey Quarterly, Emily Sachs, and Crystal Lynch, who have pulled this on and have been sending me questions and chastising me about my microphone volume early on in the chat, but more importantly, they did all the heavy lifting and getting the slides together. First time ever they have applied to an accrediting agency so that we could offer continuing education credits, and they've navigated that for their first time. And I know how intimidating that can be if you've never done it before. So I want to thank our team for this. Our next webinar will be coming out in the late spring. We're going to continue this theme of financial toxicity a little bit further with talking with some financial navigators and patient advocates about some of the tools and resources that they use when they're helping patients as they go. And in the question and answer, there's a lot of questions about whether or not we'll be offering some webinars around our disease funds. And yes, we are working a project to be able to offer continuing education credits specifically designed around treatment and processes in specific disease funds. So that's something for you to look forward to as we move into the second half of the year. So again, everybody, thank you so much for your attendance, and have a wonderful afternoon and a great weekend coming up.